So our topic in the webinar this afternoon is on transportable physician orders for patient preferences, but really focusing on the front end of good conversations and serious illness care planning to help really inform decision-making around what happens when we work with TPOPP orders. So my name's Karin Porter-Williamson. I am an associate professor and the division director for palliative medicine at KU in Kansas City. I'm also the medical director for the Kansas-Missouri TPOPP Coalition. So let me see.
The arrows, I think.
Hmm?
Arrow keys on your keyboard.
Not working. There we go. Okay, so this is a third in a series of webinars. The first session in November addressed advanced care planning, and then the second was a deeper dive into advanced care planning documents and tools with advanced care planning conversations in long-term care settings, coming from advanced practice nursing perspective, and then also TPOPP type conversations. This third one is about serious illness care planning and a model developed by Harvard and Ariadne labs that's looking from physician and team perspective about how do we talk with patients and families dealing with serious illness in a more sophisticated way. I have to say there's no conflicts of interest to declare for myself, and then a statement that the Center for Practical Bioethics is a nonprofit organization that offers membership services and products on advanced care planning to individuals and organizations on a complimentary and fee-based basis.
I think we've got a minor technical difficulty. I don't see the slides advancing.
Okay.
I just messaged Allison, and hopefully she can jump in here and give us a hand. Maybe click the slide on the other monitor. There you go. It advanced it.
Okay, good.
Uh-huh.
Let me make sure I'm... So a few acknowledgments for you guys. The slides that have the symbols that you see here have been drawn from the Serious Illness Care Program. Susan Black is the director of that program at Harvard with Ariadne Labs. Which is a combination of the Dana-Farber Cancer Institute, Brigham and Women's Hospital, and Harvard. So if you see those symbols, know that that's information that I have learned and gleaned from training in Boston with the Serious Illness Care Program. Our objectives are going to be to talk a bit about functional trajectories that patients who have advanced illness may show in the months to few years prior to death, and then to think about, for that population of folks, incorporating serious illness care planning into provider workflows for more, earlier, and better conversations about goals of care. We'll talk about recognizing the benefit of using a serious illness care planning tool to help guide conversations. And then we'll talk about the importance of how we make and document those serious illness care planning discussions, how we make those documents accessible and retrievable in electronic medical records. Then finally, we'll provide a bit of a TPOPP overview, what are the program elements, effectiveness, and some procedural components there. And Matthew may jump in and talk about REDCap and ways that tools we're using to build communication strategies amongst members of the paradigm here in Kansas and Missouri. So we know that advanced directives are not enough. Many times vague language that results in limited effects on treatment decisions at end of life. Many times they're not available where they're needed at the time. Completion rates can be low, and they may not be updated or available in the way that we need them. As we see a gap between what patients want and what they end up getting, knowing that people with serious illness have priorities besides living longer. They may be hoping for symptom management and quality of life, sense of control and completion, and then strengthening of relationships. most people say that they want to be at home at end of life and prefer comfort-focused care at the end of life, but that's often not the reality of what ends up happening. We know that 86% of Medicare beneficiaries will state that they would want to spend their final days at home, that 25 to 39% of them end up passing away in an acute care setting, 70% hospitalized in the last 90 days of life, with nearly 30% receiving intensive care in the last 30 days of life. We know that many of these folks experience care transitions that are very short, care transitions with very short hospice stays. And we know that hospice's ability to do their best work can come when the patients had a chance to be on service longer and had a chance to work through their goals, what they value and need in their end-of-life care, when that's happening much ahead of time from their actual passing away. So we also know that what patients get can harm them and their families. Aggressive care for patients with advanced illness can result in lower quality of life, greater physical and psychological distress for caregivers, more issues with depression, and lower satisfaction with care. So we know that we need to do a better job with advanced care planning, talking with our patients about this, but it's hard. Patients and families have got to be willing to talk about it. 60 to 70% of folks will affirm that speaking with their doctor and their family about their wishes is important, but when it comes right down to it, a much lower percentage, only 15 to 20% actually do. Sometimes they're waiting for the provider to bring it up. They don't want to talk about it too early. They also don't want to talk about it too late. The medical providers have to be in a position of feeling competent in having those conversations, and then also have enough time and have the right members of the patient's family and surrogate decision makers there for meaningful conversations. So there's many reasons why the conversations may need to happen, but don't end up happening in the time and space where it's best for that to get accomplished. Conversations, it also turns out, can be too little, too late, not all that great. Multiple studies show that patients with serious illness don't discuss their end-of-life preferences or first discuss them only in the last days to months of life. It was a study of patients with advanced cancer where the median amount of time before the first conversation happened was 33 days prior to death. 55% of those initial end-of-life discussions were ending up happening in the hospital. And so that means at a time of acute crisis, perhaps, rather than when the patient was feeling their best. Also, only 25% of those end-of-life discussions were conducted by the patient's oncologist. For somebody who's dealing with a cancer and its treatment, they're working most closely with the oncologist at that time. And when the conversations happen on an inpatient basis or during a time of crisis, it's more likely that their oncologist is not the one taking care of them at that time. So again, more reasons why conversations may not be happening in the time and place where they can best help the patient to think through these things. So, you know, in thinking about serious illness care planning, it made me want to take a step back and say it's really time to rename and reframe. How do we think about this? Getting away from the idea of end-of-life discussions and really turning our attention towards what's actually going on here, and that these conversations are about a person's priorities for how they want to live. That these conversations are intended to help someone prepare over a course of months or even a year or two. That this is not about people who are at the end of life right then. It's about people who are living with serious illness when they have time to ponder what their values are, what the medical information is that they are dealing with at that time, and what to expect as they move into the future. When we think about advanced care planning technology, I really love this slide because I think it helps us to think through this. What are all the elements of advanced care planning and serious illness care planning, and how do they differ from one another? When we think about advanced care planning, this is for everyone, healthy folks. And so we're looking at the left-hand side of the slide, and what advanced care planning is: a good conversation amongst family about what folks value in their living, and identifying healthcare proxy decision makers. Anyone can be in a situation where their health has suddenly declined, a bad accident, a horrible stroke that they weren't anticipating, where they're no longer able to speak for themselves. And so everyone having a surrogate decision maker in place who knows how they feel in general about things and could speak their wishes for them if they were not able to themselves. So thinking of that really is advanced care planning. When someone is diagnosed with a serious illness or chronic illnesses that are progressing over time, that's a little bit different scenario about what kind of conversations need to happen. These are conversations that must involve the patient's medical providers, who are aware of all of the medical information, can also help the patient and family work through what's the prognosis of the situation and the illness over time. What are the treatment options, and how does that patient work through the benefit burden ratios of any treatment decisions that they may be faced with. So serious illness conversations are with medical providers and need to follow certain elements so that patients and families are then able to think logically about their values in light of the medical information that they're being told. As serious illness progresses and they run into crisis or functional decline, those serious illness conversations are the starting point and a foundation for further conversations as the patient's condition and how their disease is progressing becomes more clear. And in the midst of that, they may face decisions about different treatments that they would or wouldn't want to have. So those are really our goals of care discussions and how those get pulled into the serious illness care planning framework. At the very end of life, as people have pondered and worked their way through this, then we start to think about, if things were really changing tomorrow, if I were at home and the bottom were to drop out, what do I want the medical system to do? If people have had good time to prepare and understand their condition, prognosis, and their values around it, at some point they may say, I want to have actual orders in place which represent my values and preferences for what I would want medical providers in the emergency department, in the hospital, in a nursing home setting, or with EMS to know what my values are and how those translate into a medical plan of care. And at that point is where, for those folks who want to have it in place, the idea of a TPOPP form and having a TPOPP paradigm in place really becomes of paramount importance. So thinking about all of the elements and spectrum of advanced care planning, serious illness care planning, and then how that translates into our medical system's use of that information ties this all together in a way that I think is very helpful to think about. So when is it time to start serious illness care planning? Asking the surprise question is one way that may be very helpful. Now that is, would it surprise me if this person were to die in the next year? And the answer is no, it wouldn't surprise me. That means it's time to start thinking about the elements of a serious illness care planning conversation and introducing those concepts to the patient and family to think about. It's important to note the surprise question is not the same as saying that someone has a prognosis of a year or less. The surprise question is a clinical assessment based on many elements of our judgment that come into that answer. And usually something that the doctor or advanced practice nurse who's taking care of that patient has a continuity relationship with them or is familiar with all of their diagnoses is thinking through. Recognizing functional trajectories can also help. So we're going to go through a few of those now. This is the non-cancer illness trajectory. So this is chronic medical conditions that build up over time, organ failures that start to make it harder on the body as a whole to function together. So congestive heart failure, renal insufficiency, liver disease, chronic lung disease, all of these things fit the pattern. And about 60% of people die on the non-cancer illness trajectory. And so more than half of us end up facing this situation where you're trekking along at one baseline and then the bottom drops out. You go in the hospital, we tune you up, you get better, but not quite to where you were before. We truck along at the new baseline until the bottom drops out again, and then we tune you up, you get better, but not to where you were before. This is a very common pattern that plays itself out over a matter of months to sometimes a few years. And the hallmarks of it, that the overall slope of decline is one that's an overall slope, even though it's accentuated and punctuated by periods of sudden crisis that usually people are able to recover from. But at any one of those crisis points, the person could end up passing away. This trajectory is really important to pay attention to. If somebody is on that trajectory, they can go from being as good as they get, as stable as they are, to very, very sick very quickly. And so once that trajectory is recognized, having conversations about if the bottom were to drop out, what are the things that matter the most to you? It's a conversation we have very commonly here in the hospital with our palliative care consult patients. It's very helpful for them and their family to be able to understand the pattern of illness so that they know that they haven't necessarily been doing anything wrong in their care, but that's how the nature of non-cancer illness changes over time. So said a few of these things. So, you know, doctors sometimes don't even see this coming up to the few days before because the patient was as stable as they can be. These folks end up in the hospital and in the ICU when they haven't made decisions beforehand with a plan in place about how to prevent that from happening if they wouldn't want it to happen. It is not an unusual circumstance for me to get called to the ICU on a new consult, somebody who went into a rapid respiratory or multi-system organ failure and ended up on life support machines with their family coming in from out of town saying, "Mom would never have wanted this. How did this happen?" We had an advanced directive that was in place. And so when we think about how the system needs to be tied all together, it comes back to these trajectories of illness and the preparation that we've all done ahead of time to help understand and honor someone's preferences all the way through and at every point of care. So let's see, the other trajectory that's important to talk about here is the frailty dementia trajectory. This was one that's important to talk about because these folks can live at a very low level of functioning and may be incapacitated for a long period of time before they pass away. Because we know that those folks may live in a place where they're not able to provide their opinion, having these conversations earlier while they're able to tell us how they feel about things is important. What makes this trajectory kind of tough, though, is that we can see it in retrospect more easily. Sometimes gradual weight loss and them not being able to participate and tell us what they think. So this is majority in the nursing home setting where at care planning, we come to realize after the fact, oh, this person's been declining, and that's part of their natural progression of disease. So planning on the trajectory, what people need to know. If a person would prefer to not die in a highly institutionalized setting with things happening to them, tests and poking and prodding, they and their loved ones need to know their trajectory and make a plan for the next crash. This requires planning from the system and the provider to recognize the trajectory and be competent in discussing that. It requires planning from the hospital and the provider's office, nursing home, if the patient's in a long-term care setting. And it requires the support of community systems in a coordinated effort in order for us to do a really good job of matching the care we're providing to the care that patients tell us they are wanting at that point in their living. Conversations are really key. Earlier conversations about goals and priorities for living with serious illness are associated with enhanced goal concordant care. That's where what we're doing and what the patient is saying they're hoping for match. Improve quality of life, reduce suffering, better patient and family coping, higher patient satisfaction, and less non-beneficial care and costs. I think it's really important to put all of this into the context of the value equation. So value equals quality divided by cost. And we seek high value care. And the reason that we push conversations and having patients and families with an opportunity to have a really good understanding of this is that that is the best practice in providing quality interdisciplinary communication. It turns out that when we do a really good job of that, and when we do a good job of teamwork and coordination, it ends up, as a side effect, costing less money. That is not the driver behind providing the best practice. If it's a side effect, then all the better, and improving the value of that person's care. When we think about having these conversations, it's important to know that subspecialty palliative care providers can't provide this care to all patients with serious illness, nor should they. I know many internists, family medicine doctors, oncologists, heart failure specialists who recognize that this communication is important and that they should be prepared and have basic level of competence in having these conversations as a part of their job. But they're hungry for the skills and tools to be able to do a better job of this. And so we know we don't have enough palliative medicine physicians to provide access to this skill set for all the patients who need it. And so this serious illness care planning idea is a scalable intervention targeted at generalist physicians or non-palliative care physicians and other clinicians to assure universal access to this key element of palliative care. So the Serious Illness Conversation Guide, very useful tool to improving conversations. And so we're going to talk about this guide here in just a little bit, and some of the other communications training that can go around it. When I went to Boston in the Serious Illness Care Planning Program, there were sessions where we were able to work in small groups and with standardized patients to practice using the communication guide. I'm working with the Center for Practical Bioethics and our team on building that type of curriculum to be able to do more in-person training with folks as an adjunct to getting this information here today. We know that communication skills training programs work. The key elements of those: cognitive input, modeling, and then skills practice. And that when we do a good job of that, improvements are maintained over time. This is the kind of core serious illness conversation guide that we use to walk through a serious illness conversation. So I'm going to spend quite a bit of time going through this. Checking my time here a little bit. I've been working with this guide since I went to the training last summer, and we've built some tools into our electronic medical record to help us document these conversations. But I actually use this tool when I am having a serious illness conversation with one of my patients, and we'll talk about the reasons why to actually have the paper there to help remind me, even as a palliative medicine specialist who does this all the time. So there's two sides to this guide. One on the left side shows you the conversation flow. And then on the right-hand side, there's patient-tested language about how do you actually say How do you actually say these things in ways that patients feel comfortable with? And so it's important to know in the development of the guide, the Ariadne Labs folks have worked through multiple iterations of the guide and improved it as an iterative process. And it continues to evolve and change. I think this is, someone was telling me this was like the 80th version. So the first thing is to set up the conversation, introduce the idea of a serious illness conversation, and ask permission. Is this an okay time to talk about this? Is this something that you're willing to be able to ponder with me? And words to say. I'm hoping we can talk about where things are at with your illness, where they might be going. Is this okay? The next is, once you have permission, is to assess illness understanding and information preferences. Having this on the very front of the conversation is absolutely critical to knowing if the patient's been given other medical information before. Have they been able to really comprehend it? Did it stick? Have they thought through that at all? And do they really understand what that is? So saying, what is your understanding now of where you're at with your illness? And then how much information about what's likely to be ahead with your illness would you like from me? Some people want to know absolutely everything that's going on. Other people would prefer that we talk to someone else, one of their loved ones, about it. So knowing how open they are to receiving information is really important. When you ask that question about help me understand what you know, you'll get all kinds of information from them. Some people will have a very good sense of it, and you can tell they've thought through it a lot, that they've walked themselves quite a ways down what their goals and priorities are in relation to their illness. Other times you'll know that that person's been told medical information repeatedly, but they'll answer that they haven't been told anything. And that's also a very important thing to understanding where are they at, and do I need to use different words, or is this information too difficult for them to ponder? Once you have a sense of their understanding of the illness, then sharing prognosis and talking about what to expect is the next really important part of the conversation. Tailoring that information to patient preference. And then once that information is shared, really allowing silence and exploring emotion. So this part of the conversation can be tough. And when we work in teams, we know that different elements of this conversation may be brought forth by a social worker, by a nurse, by a care coordinator. When it comes to the sharing of prognosis part, it's really important that the physician, the advanced practice provider who's really owning that person's plan of care, be included in sharing that prognosis. In my role as a palliative medicine doctor, I'm oftentimes gleaning information about prognosis from the patient's oncologist or their heart failure specialist, from their primary care physician, and then I'm communicating that with the patient. Sometimes they need to hear it directly from that doctor they've known and trusted for a long period of time. When we think about these conversations, this is an element where the medical providers need to be involved in order for the patient family to really be able to grapple with that information. So there's also a couple different types of prognoses or ways to talk about it. We can think about prognosis in terms of time, length of time, and then we can also think about prognosis in terms of function. So some people will want to know what is the range of time, and the best we can getting them into a range of what to expect. With some diagnoses, it's more a matter of not knowing. Time can be incredibly variable, but the maximum function that somebody has may come to be very well known. So describing prognosis in that way for some conditions is more accurate. Once that prognostic information's been shared, next is very important to explore some key topics about their goals, about their fears and worries, sources of strength, what critical abilities are to them in their living, what trade-offs they would or would not be willing to make for the possibility of more time, and then how much does their family know about this. So these key topics really put a framework around how does somebody hope or intend to want to live in light of all that medical information and the prognostic data. So there's several really good patient-tested language scenarios on the right side. What are your most important goals if your health situation worsens? What are your biggest fears and worries about the future? What abilities are so critical to your living that you can't imagine living without them? I think this one's really telling. When I've made this statement that if you become sicker, how much are you willing to go through for the possibility of gaining more time? People that resonates with them, and they're able to think through that about what they would or wouldn't be willing to go through, gives us a good sense of where they're at in terms of medical treatments that they would find palatable or not palatable at any particular as their illness progresses. Then finally, how much does your family know about your priorities and wishes? We know that a lot of people become incapacitated near the end of life. And so that many, many times surrogate decision makers need to be able to share in that decision-making process and stand up for the patient and say the patient's preferences. So including the family in that to the extent that the patient is comfortable with is really important. Then closing the conversation, summarizing what you've heard, making a recommendation, and then affirming your commitment to the patient. So when I'm in these conversations, I want to state back to them what I understand from them so that I know I have it accurately. And then when I hear somebody tell me what their values are, if they'd want to be at home, if there are trade-offs that they either really would or wouldn't be willing to make in their care plan, then what I can do is take what I know about their medical situation and what's on the table in relation to treatment options. And then I can say, well, based on what I'm hearing from you about your goals and your values, this is the medical plan that makes sense to me. And then you go back and forth about that. What do they think about that? And then you really end up with a patient-centered plan of care. After all of that conversation, then documenting the conversation in a way that conveys those messages to all the other treatment providers who may run across the patient is really critically important. So I actually have this thing printed in color and I keep it with me and I use it as a tool to remind myself. Now you might say, you're a palliative medicine specialist, why do you keep a piece of paper with you? It gives me the actual words when I feel stuck. You know, a lot of times the residents, the fellows, the nurses that we work with all over the place say, I just wish I had the exact words. And when you're in a stressful situation, when a conversation is emotional, it's good to have those things there to remind you. So also reminds me to cover elements of a conversation more systematically so that I know I've covered my bases in the same way each time. You do have to remember, if you're using this thing, that it's a guide for the conversation. It's not a checklist to complete. And that if that piece of paper becomes the centerpiece of the conversation as a checklist, then the quality of that conversation is going to go significantly down. But the guide can give you a structure to the conversation that naturally triggers meaningful responses from the patient. To give a rich sense of what that patient's goals and values are. So what else do checklists do? You know, they bridge the gap between evidence and real-world implementation, assure adherence to key processes, achieve a higher level of baseline performance, and importantly, ensure completion of necessary tasks during complex or stressful situations. So at KU, just simply as an example, what did we do in our electronic medical record to try to work to make advanced care planning conversations and documents obvious? So in everybody's system, you'll have your own own ups and downs of the EMR, but I think it's always helpful to kind of have examples of what folks have done other places. So we try to unify in our electronic medical record the inpatient and the outpatient header that's at the top of the screen, so that there's a one-stop shop for advanced care planning related items. And so you can actually interact with the icons in the header on the code status, and then we have an icon for advanced care planning and then one for TPOPP, where if you click on it, it opens up an advanced care planning report that shows their inpatient code status history. It right there in the report shows links to any PDF document that they would have scanned, so any advanced directive, power of attorney for healthcare. If they have a TPOPP or an out-of-hospital DNR form, 2 clicks out of the header to see the document there, the scanned actual document. Also links to the policies related to advanced care planning. And then underneath that, in the report, there's a link to any advanced care planning notes that have been created in the system. So we made an ACP note type in the computer so that whenever somebody has an advanced care planning or goals of care conversation, if they document it on the advanced care planning note type, then that note will file to the advanced care planning report. And they file so that the newest conversation is first, and then you can see them in line in reverse chronological order. So most recent conversation first down to the oldest conversation last. The thing that's important about this is that, a lot of times these conversations get stuck into a progress note that gets buried in an encounter. And so when somebody shows up in the emergency department at 2 in the morning, that it's impossible for the providers to pull out that conversation, which is highly relevant at that moment about what that person, where they're at in their understanding of illness and what they want to see happen. So using this advanced care planning note type tool and then also the framework around that conversation in the note provides a very easy access to conversations as they happen over time across multiple places in the system. So this is a screenshot of the header where you can see what you can click on to get access to the report. This is the actual advanced care planning report with the code status, and then you can see documents filed to the patient. Then below you can see advanced care planning notes, all the ACP notes, and 2 of them that are there. What you're seeing here is the framework of the conversation. It's a smart text that you drop that opens up automatically when you open up the note type. So outcomes of serious illness conversations. No decision may be made, but the conversation's documented in the medical record. We've just described a way for that to be easily accessed by other providers. Needs to be documented in a way that conveys that person's current goals and wishes. And it's important to know that these types of conversations since January of 2016 can now be billed using advanced care planning codes, and that the qualified providers who can do that are physicians or advanced practice nurses. Other outcomes of the conversations. The patient may want to complete an advanced directive or a power of attorney for healthcare decisions, or they may want to have their preferences translated into actual provider orders that follow them across the continuum of care. And for those folks, TPOPP is the tool here in Kansas and Missouri that we use. So I think what's interesting to me, we've worked on TPOPP for a long time, and we've built all of that community infrastructure in many places, working on how to tie together hospitals, nursing homes, EMS, hospice, to have kind of the railroad tracks built for TPOPP forms to move. Now that those railroad tracks are built, the other side of that coin that we've got to be very good at are these serious illness care planning discussions, so that when someone wants to have that type of document in place, then the train can move on the train track. So they really go hand in hand together. And if somebody doesn't want to have those orders in place, then the other remnants in the medical records, so the documentation of the conversation being easily accessible, other easy access to other types of advanced care planning documents, are all of the things that will go to helping us do a better job of increased goal concordant care. So putting a serious illness care plan into action. Think about developing clinic and institutional algorithms that help to identify the seriously ill patient, where the surprise question is no. And how we do that across big enterprises can be a bit of a trick. But the more the system can do to identify that population of people, and then for providers to say, is this person one where I really need to have a good goals of care conversation and be thinking about this in a different way? So there's identifying the patient, but then there's also developing workflows and training for those providers to have more, better, earlier serious illness care planning conversations using the guide. And so there's more to come on training and practice for that. If anyone's interested in that, the Center for Practical Bioethics is going to have new resources and opportunities coming out in the coming months for that training. We need to develop documentation tools that make the outcomes of serious illness conversations as obvious as the allergies in the medical record. And then for patients who wish their treatment preferences to be translated into transportable orders, we need to have the tools and the institutional community infrastructure necessary to create and honor TPOPP documents as they move across the continuum of care. So putting it all together, back to this slide that I love so much, from a community perspective, what should the community be focusing on? For young, healthy people, that means focusing community resources and public education on the importance of discussions, naming trusted surrogate decision makers. For folks who are seriously ill, that means medical providers and medical systems thinking about how do we raise the bar on good goals of care conversations? How do we raise the bar on our system tools to make the conversations more obvious so that the information is shared amongst medical providers more easily? So that medical system infrastructure to make documents as obvious as the allergies. That really hit home to me when I thought, I can always see what the allergies are. It should be as simple to be able to access somebody's global goals of care for their treatment plan. And then as we move towards shorter prognosis and the reality of what might happen tomorrow in that patient's care, when it becomes as granular as that for the patient, for their family members, and for the providers taking care of them, that's where we really think about, do we have actual orders in place that move with the patient? Now, some folks who are seriously ill, where the surprise question, the answer is no, they may want immediately to have orders in place with them that move across the continuum of care. Some people may not, they may know how they feel about it, but they may not want to have orders in place yet. So knowing that different people may want to handle that in different ways. But do note that when we're talking about somebody who's healthy, who is not dealing with serious illness, that's the other end of the spectrum from TPOPP. That TPOPP is not an appropriate tool for somebody who is otherwise healthy and needs the further upstream advanced care planning tools. So understanding how all the tools fit into where that person is in terms of their living and what health conditions they're dealing with is very important to understand. So serious illness care planning will be the most effective when we have all of those pieces in place. For someone who wants to have orders in place, we need to have, and communities need to have the system infrastructure built and ready to go. If you're not in a place where you have a community coalition working, for TPOPP to be active, it's very important to know you can't just get the forms and start filling them out and sending them around. The community has to say, we want this in our community, and all work together. All the elements of that medical continuum work together to understand what it is and have appropriate policy and procedure in place for it to work optimally. So the next steps really are thinking about how to develop and implement a TPOPP community coalition in your area, if that's something that you want or that you think is important for where you live. So thinking, I'm just checking this one out. So the next steps, if that's important to you, are thinking about how do I organize from my one place, organize a community coalition, and then thinking about how do you get started. What are the roles of institutional providers and individual clinicians in that process? It's important for you to also know what the ties are to work statewide in Kansas and Missouri in terms of policies, procedures, regulations for EMS, those sorts of things in place. So I'm going to turn it over a little bit here to Matthew Piecka, who's going to talk about what some of those next steps might be and what resources the Center for Practical Bioethics has in place to help.
Sure, if you just want to, yeah, okay, thanks. Hi, my name is Matthew Piecka. I am staff to the TPOPP steering group, and also I do some of the data and kind of logistical organization on the like kind of the other side of the curtain for this group. And I'm going to talk a little bit about REDCap and our research tools and how they work. For interested institutions that are interested in implementing TPOPP, we kind of step one for us is for us to get in contact with you, and then we send what's called an institutional profile survey, which is a tool that's implemented through the REDCap Research Electronic Data Capture platform, which is just an open source research collection platform or data collection platform. And the institutional profile is a survey that is designed to capture a bunch of details about your given institution and kind of where you are in the process of implementing TPOPP. So your initial response to the survey would likely be the types of education that you're interested in getting for your employees, who the points of contact are at your institution for TPOPP, and who your institutional partners are who would likely receive TPOPP forms that you originate. Can you advance this slide? Mm-hmm. I'm not sure if it's just that one, but yeah, I think it's just that one. So there's a couple things that are important to note about the survey. It's designed to be taken multiple times, so we try to send it out semi-regularly, every 6 months or so. And when you receive it the second time, our goal is to have it. We're just sort of getting this project up off the ground, but our goal is to have it type in your responses from the previous survey, and then you can just update whatever has changed in the interim. And then we take that data, and anytime you get in touch with us or we get in touch with you about possible training opportunities, we have this nice little profile that lets us know how best we can assist you. And then in the long term, it gives us a kind of a high-level strategic look on how implementation is going across Kansas and Missouri, which informs the way that we move forward, helping establish this as the standard of care. That's kind of it for REDCap right now, I think.
Yeah. All right. We're going to try, hopefully, we're going to try to show you a little bit of a TPOPP video here as an overview. Let me hope, I hope it works. Okay.
There's a chance that browser window will launch on a different monitor. Why don't you click your little Internet Explorer guy down in the corner there?
I had it on mine.
Well, I might be able to do this actually. One second. Okay. Yep, I've got it here. So why don't I just play it from mine?
Can you see it?
Mm-hmm.
Hey, Matthew, I don't.
What's up? Is it not piping the audio?
I have.
All right, yeah. Unfortunately, we'll probably just have to send this link out to the people who are on the call today. It doesn't look like this is wanting to play quite nice with us, so. All right, well, why don't we just kill this? And if there's anyone who has any questions, I mean, Karin, do you have anything else that you'd like to go over before we turn it over to the floor?
No, I think have about 10 minutes here for questions, other comments, so we'd open it up.
Sure. For everyone who's on the call, there's a little Q&A widget that will be in your little Zoom toolbar. And if you click that, you have the option to submit questions to us. We had a couple already. A common question that we get is how to secure the slides. And we send them out on request in like a PDF format. And so if anyone's interested in getting those, you can just drop that in the Q&A widget or in the chat widget and let me know, or shoot me an email, it's fine too. And if anyone else has any other questions, they'll pop up for us and we can respond to them there. We had one a little bit earlier that was asking if it would be possible for Dr. Karin to include some screenshots of the EMR with info about the advanced care planning tools in your EMR into the slide deck. And I think you had a couple screenshots, right?
Uh-huh.
Yeah,
I think my question for that viewer would be, as we went through all of the slides, did they end up getting, I tried to pull out the most relevant screenshots, you know, for all the tools that we have in place. So it'd be great to know from that viewer if they feel like their question got answered.
Okay, great. And we've got a couple here. One is, are you suggesting with multiple hospitals, or are you working with multiple hospitals or just the University of Kansas Hospital, suggestions on implementing TPOPP in different health systems?
So I have a couple different roles. One, as the medical director for palliative care at KU, I've been the kind of lead physician for implementation for KU health system. So that's in the physician practices across our health system. We have a community coalition here in Kansas City where the different hospitals, you know, in the city who are working on TPOPP are implementing in their own institutions, and I communicate with the various members, you know, of folks at those institutions. And then at a statewide level, in Kansas and Missouri, there are community coalitions who are working across Kansas and Missouri. Are there pictures of the maps on the Center for Practical Bioethics website, Matthew?
Not presently, because we're in the process of updating them, but they will be soon. Yeah.
So, Matthew, I don't know, every time we turn around, there's more and more community coalitions who are working. Matthew, you want to provide a little update about where community coalitions are across Kansas and Missouri?
Yeah, I've actually been working on a new tool, and since we're here, there's no reason why I can't kind of give a little peek at it. So let me load it up really quick. It's got, so I've been kind of collecting all of the coalitions that we're currently working with and listing them in a database. And now, let's see. Can you see that all right, Karin?
I can see it.
Okay, and so can our viewers.
They can.
So this is a spreadsheet that I've put together that shows all of our existing coalitions, and they're in varying degrees of implementation. Many of these ones are actually readied, Yeah, see, we've got the University of Kansas Medical Center in the community. That's our community coalition, Kansas City, and we actually show. See, there's your email address there, and all of these guys are hot buttons. We actually show these different communities. So as we get new institutional profile responses, they get added to this database, and that starts to help us take a picture or get a picture of how many communities we have rolling along. Yeah, some of these, like, I haven't gotten around to actually adding the institutions themselves. This is just the community coalition, but you can see like active. I think we've got one around here that's developing. But yeah, that's kind of a little peek at it right now.
Great.
Yeah, pretty cool.
That is pretty cool. All right, I see some other questions in the question box. What we got there?
All right. Looks like the viewer who was asking about the screenshots is happy with the ones that we had. So
okay,
we can
great.
move on from there. Let's see. Someone was asking how we begin to do research into TPOPP and implementing. So that's really what the REDCap tool is all about. And we hope to eventually start implementing additional tools outside of just the institutional profile to actually track like the number of TPOPP forms that are originated and how they move and get a sense of how effective they are at achieving their goals.
At a national level, there's a growing, pretty extensive body of research that can be accessed through the National Pulse Paradigm website. So if you go to www.polst.org, there's a pretty extensive array of papers that have been published, which look at the effectiveness of these paradigms and improvements over our traditional advanced care planning tools. So I would, for understanding of our current knowledge base around effectiveness, I'd refer you to the pulse.org website.
All right, and we have one more here that is, will the serious illness conversation guide be available with slides or separately? It is in the slideshow, and it's also worth noting that all of these resources, all of the Ariadne resources are available on Ariadne's website, which I think is Ariadne Labs.
Yeah.
Ariadnelabs.org. So if you're interested in securing that, securing those documents, you can find them there.
There's actually through Ariadne Labs, if you go to that website, you can join their serious illness care planning community. There's a lot of online resources there, tools, and then if you are interested in the idea of in-person training through Ariadne Labs, that's how you would find out about it. That's how I find out about it in the first place. So, and we'll be providing more information on more local access to curriculum around that in the coming months. We're developing that right now.
All right, I got one more here that is Linda Carroll, you have Ariadne spelled correctly. It's Ariadne. I've got one that is, how do you apply for the REDCap program? So basically, if someone emails tpop@practicalbioethics.org with an interest in starting an implementation program, then we work on integrating you into the institutional profile system, and then when we send out the next round, that's when you'll get it. So we're preparing to send the next round. So anyone who is interested in sort of launching their own program, let me know, and I'll get you integrated there.
So that contact email is the last slide in the set. For Kathy Greenlee or Matthew Pieka, the project leads at the Center for Practical Bioethics. And so when you get the slide set, that email address is the last slide.
Yep, I'll post it here on the question as well for anyone else who wants to see it. Let's see. Thank you as always for the information. It seems to me that there is a wide span of time, ideally, between palliative care consult and the eventual hospital referral. I'm thinking that from an insurance perspective, benefits for palliative care may need to increase to support to support offered to patients and families. Do you have any comment about that, the Diane Pence comment here?
I think the only thing I would really have to add would be when we think about somebody who's seriously ill, before we kind of label them, you know, as now we get palliative care, put them in that bucket, all the providers just think about, what am I doing with goals of care? Does the patient know how seriously ill they are? Have I communicated with them about that and listened to what's important to them? As just part of what is good medical care for somebody who's very sick. I worry a little bit about us labeling people, putting them into a quote-unquote palliative bucket, when it's a little bit nebulous. So I think about the core principles of palliative medicine being just plain good medical care and interdisciplinary teamwork for somebody who's really sick. And the time, you're exactly right, that the time we should be thinking about that is significantly upstream from where most providers think about it right now. And so I'd even want to stay away from labels of palliative, are they a palliative care patient or not? Because that gets very confusing. If they're seriously ill and they're dealing with serious illness, then just saying what's the best medical care for them and how I communicate with my patient about that. So thank you for that question.
All right, we've got one more little comment here saying that the serious illness conversation guide isn't very easy to find on the Ariadne website. Maybe there's an outdated version of it. So I'll send it out. I'll send out the PDF of the one that we have with the slides for the people who requested them. Yep. And if anyone ever needs to get in touch with me, I'm M. Piacha. I'll bring it up here so you can see. And you can just shoot me an email. Yeah, so there's my email and my direct desk line. So if anyone needs to get in touch with me or wants to request anything after we go offline, you can send me a little message and I'll see if I can help you out. And I think that's that for the questions we've got, and we're just over the hour now. So unless anyone else has some pressing issues, I think we're probably good.
Okay, thank you everybody. Have a great afternoon.
Yep, thanks for tuning in. And we'll get this up on our YouTube channel. For anyone who's interested in seeing this kind of material, we're generating more and more of it in the coming months. So subscribe to our YouTube channel. It's youtube.com/practicalbioethics. And I think that's the URL. That's user/practicalbioethics. But you can find a lot of these resources there and other TPOPP resources as well. And we expect to be doing more of this in the future. So thanks again, guys.